especially our C4 folks. For those of you who have never actually seen the OD report, this is what it looks like when it's running ad hoc. And this is what we get every morning when we do this. When C4 gets it every morning, it looks through it. It's triggered by your impressions of overdose. I put overdose plus because it's like a overdose unknown, overdose opioids, whatever. Those are the triggers. A Narcan administration in the field, all those things trigger the report and show it up on there. And then we kind of go through it and we read it and kind of look at those the PCRs and figure out who can we connect with, who can we find is a huge part of it. Because if there's no way that we're going to find them, then there's no point in sending somebody to run around in the woods behind whatever, just shouting somebody's name. It just doesn't work very well. But we look at it and say, hey, can we have a meaningful conversation with this person? Do they need a conversation about harm reduction? Do they need a conversation about substance use? What can we help with? And that's the whole point of it all, right? To look at this and say, hey, where is this person? How can we help them, and what can we do with them? And then the Narcan administration, and there's intervention for leaving Narcan kits behind. That's in ESO. If you're talking to field crews who talk about leaving a Narcan kit with somebody, please ask them to mark that, because we record that and there's left, but I promise you there's grant stuff attached to that, and we'd really like to know about the Narcan kits going out. So C4, we've moved the responsibility of doing this to C4, and their job is to kind of do it. They're the eye in the sky, and they're able to see all this for us, and it's super helpful. They get super busy. We completely understand that, and some days they come in and they typically have like one person on at 7 a.m. and for like hours. There's one person flying solo, and they don't have time to get to the OD report. So as soon as Lo, Adam, or I all check in, soon Dom, come in the morning, the first thing we do is check in with them, say, hey, have you guys gotten around to it? Is there anything we can help with? And kind of go back and look at them. And then we assign them, right? When we assign them, button thing. Okay, so everybody can do this. Anybody can do this. So you guys that are running responder calls or whatever, something like that, if you happen to go on an OD call or you get dispatched to an OD call or something like that, and you have a conversation with somebody, what we're doing when we look at that report is we're going over here to where it says cases and alerts. And we're going over here, we're clicking on the alert and making it an OD alert. Everybody can fill that in. And then once you mark it as pending or assigned or anything like that, it populates on this dashboard every day. And so that's what we're doing with the report every morning, is populating it onto that dashboard so we can figure out what we're doing next. So when you open the OD alert form, this is what you see. Some of these are required fields, some of them are not, obviously. But if you put it assigned, it'll give you a spot down here to assign it to a person. That helps us with accountability. We know, like, okay, cool. There's 7 of them on here that need to be addressed today. We've talked to the on-duty chippers, and it's, it's Jake, it's Kenny's filling in on a chipper that day, and whatever. And we assign it to them. That way we can look back at it at the end of the day and make sure somebody got to it. Because if you guys get busy, if you're assigned an OD alert and you get busy and you don't get to it, cool, that's fine. We'll get it worked out. It's not a thing that we have to be there immediately or anything like that. We need to get to that person within 48 hours if we can. So we'll try and do that. So the other part of it too is if you go to visit somebody or you go have a conversation, like say you go to the hospital to interact with somebody and that person's unconscious and there's really no point in having a conversation to them, if you mark that profile with the revisit, it puts it on the dashboard, and then Adam, Lowe, and Dominique and I know that we need to circle back to that person and go try and have another conversation later on. But if there's any reason that you feel like you want us to come back to that or circle back to that, putting it on the marking it as a revisit makes it a lot easier on us. So why we do the OD report, I put this up here. This is a direct quote from a letter that I had. I sent you guys the letter, and I said, so I've shared it with a couple other people, but it's from the very first OD follow-up that I ever did. He knew he was the very first one because he kept asking me, like, is this a thing you guys do? And I was like, trying to make it a thing. It's trying to be a thing. Now it's a thing, right? And now it's a thing that we all do. And I always say that he articulates better than I ever could about why we do this, right? Why we touch base with these people, because they need our help. And they're in that scary place between becoming and being when it comes to recovery and addiction and active use and stuff like that. And so we're just trying to be there in that scary place that exists between. Anybody wants this letter, let me know. I'll send it to you. BBP rules. Just want to clarify a couple of things. You want our help, you need our help, you participate in our help, right? That's all we're asking, right? Do you use opioids? Are you experiencing withdrawal? Okay, that person needs our help. Like, do they want to stop? Do they want to get engaged in services? And what that's the other part of it, right? That we need that. And then they participate. If we set an appointment for somebody and they don't go, what are we doing here? Why? What are they doing? We're asking them to participate. If we say, hey, we're going to meet you tomorrow at noon at this time at this place, I get it. Shit happens, especially when you're living in a difficult situation of you're using every day and stuff like that. Like sometimes we're not gonna make it, but at least try and work with us. Don't ghost us for multiple days. But we're still gonna come back to them and still give them a shot. Does that make sense? Required documentation. This seems to be getting missed on a regular basis for whatever reason. So there's basically 3 kinds of dosings, right, that we're doing with buprenorphine. There's an initial enrollment, which is somebody who, I called it earlier, natural withdrawal, like basically who's using on a regular basis, who is just trying to stop and then has gone a period of time without medication. That's an initial enrollment. That's the first time that we've seen that person. We need a PCR on that person. Like that's a new contact, new case for us. And so that's where we want to get one of those, an ESO. Emergency dosing. Emergency dosing is what we call it when somebody has a prescription, they're connected to a program like community care or CMS or Oshbach or wherever it is, and they're getting it. That's still the first time that we've dosed somebody. They still need a new PCR, right? They still need an ESO chart. We have initially dosed this person, gotten them started, established what their dose is, and we're going to come back to them and see them on the 2nd and 3rd and 4th day. We've already got an appointment lined up. This is somebody regular working. Apricot is sufficient for your documentation in that one scenario, but that's somebody we already have an active case on. All that stuff. Make sense? So when you go into when you start a brand new case, for example, right, when we're doing somebody new, you come up here to this part right here and you mark support case, assign it to yourself because that helps us know where it started. That doesn't put you on the hook for anything else. Like, it doesn't mean like, well, Sarah's supposed to do this one every day from now on when she's off. We're not looking, but it helps us track it. Support case status is active. This is a required field. Enrolled in BBP. This is kind of what we're talking about, Randy. Like, once you mark this as a yes, it opens up this. If you don't mark this as a yes, you don't see this, and this doesn't populate on the dashboard, right? It's when you mark the treatment status right here as active, that's what populates it on the dashboard for us. So that's also not a required field. That's what we're hoping to make a required field for those together. So the trick is, as long as when you start somebody new, enroll them in BBP, mark that as yes, as active. This is, whether it's planned or whatever it is, that's fine. This is the most important piece of it, because what happens is when it's marked as being active BBP status, that means that we are going to come back to it. We're going to see it on the dashboard when we do it. If it's not marked there, we might miss it. And that's important because that actually happened this weekend. Where we almost missed it because they didn't fill out the thing. They missed whatever it was. We hadn't explained this yet, I guess would be the better way to say that. But fortunately, he sent an email and Dominique caught it, and we ended up sending somebody out there again to take care of. So, okay. So documentation expectations as far as like your narrative notes and stuff like that, when it comes, it's like, tell us what happened yesterday. Like, how you write your narrative is up to you. It's fine with that. But I'll tell you what information we're looking for on the substance use side is like, tell us what happened yesterday, what led us to be here, or what preceded this interaction with us. Let us know what happened during your interaction with that person. Like what you did, if you dosed them, if you called in for some comfort meds, if you got them some quantity, if you did whatever, all those kinds of things, put that in there because we're gonna look at that. And then most importantly, what's the plan for tomorrow, right? Meaning that you've gone out and dosed somebody and you've told them like, hey, we're going to see you, we're going to call you at 10 a.m. and we'll get you started. And they say, well, I've got to work by 1, so I need to do that. Make sure you put that plan in the base of in the bottom of the note so that we know we can back up whatever it is that you promised. I just want to back up what you're telling them, but if I don't know what you promised them, I can't back you up. And that's what we're asking for. Okay. Process.
I have a question.
Yeah.
Is there any, like, so plan for tomorrow and set her up. Are there any things that we should be aware of for you guys? Like what is too early? What is too late?
I mean, if you commit us to being there at 6 o'clock in the morning, I'll get up and I'll come in at 6 o'clock in the morning to do it. But if I don't see that you've committed me to being there at 6 in the morning till I come in at 10 and I'm looking at the notes, then I don't know about it. So, like, we got to figure out a way to let us know ahead of time. We're generally going to try and be here. I'm usually here by 9 at the minimum. I usually say 9 is my time, and I start here at like 8:30 most of the time. So for me, and then once Dominique gets cleared, I think she wants to do earlier morning, so there might be some room to do that in there. Lo tends to work a little bit later. Adam's all over the place because he got kids. So yeah, I mean, like, if we know that there's going to be somebody, but the other thing is we have 24-hour people, right? So if it's going to be something really early in the morning, we don't want to ask somebody who's at the end of their shift, can you, get up early and come do this? But if we got it, we got it. Right?
So would it be fair to say if there's something going to be before 10, just make sure you have positive contact with somebody?
Yes.
So that we know that somebody will be doing it in the morning and it's not one of those emails that get lost in the ether.
Yes, that's better. Okay. So I called it the birth of no a while back, right? Because up until a certain point, we were just being everybody's everything, right? You ran out of meds, you lost your meds, whatever it was, we would just come take it and we would dose you and we would carry you all the way to it. And then we had the perfect storm of difficult clients happen like on one Monday morning, right? We're like, okay, we can't be everybody's everything. And I think we went back and said, okay, if you're already established with the program, we're going to send you back to your program. We're going to do it and we kind of put some hard rules in. And I think we got a little too far away from the point of like, we're supposed to be supporting people who need help, right? And the whole point of the program is to support the people that need help. And so I don't like saying no. So we kind of tried to trim that back, and we put the BBP caution, not the high alert or dose or anything like, or no, I think we used to say, do not dose without contact first or something like that is how we had it worded or something like that. It seemed all pushed us all towards the idea of telling people, no, we don't need it. We're not going to give you medicine. And I think that that's something that we need to be very, very careful of, because the alternative to us giving people medication is they go out and use. And with the state of the drugs in the community right now, we're pushing them towards a very risky thing that could possibly kill them. So we really want to be very careful when we tell somebody, no, we're not going to dose you, right? Does that make sense? Like we don't want to withhold things and push people into that. But at the same time, we also need to not allow people to abuse our services and push you guys into a certain, and nobody, like, we shouldn't allow somebody to be disrespectful to you or just demand things from you and all that kind of stuff. So you have a no in your back pocket of going, you know what, I don't feel comfortable with this, but we need to be very, very careful. We try and stay on top of this list of people that are marked as high alerts or cautioned, I think is what we're calling them. We try and stay across that list. The idea for that is something's going on with this person and we should be very careful. Like we had, there's one particular person out there in the community who has a very bad habit of lying to us about how long they've been since they've used and saying, I just can't get my medicine and all that kind of stuff. And the reality is they're still using fentanyl and they're still using other drugs. And if we just take everything off of what they said, we're going to possibly send them into precipitated withdrawal because we're going to dose them without having a cow's, without them needing a cow's to make them actually sick. So if somebody calls and says that they are sick and that they want help, we should go there and see that person first, right? The idea to say, oh, well, you're already established with a clinic, you're all over the place, let's get you back to your clinic and do that. Make that decision or have that conversation from right in front of the person. Go see them first, because I think all of our docs would agree if somebody's calling with the complaint of, I am in withdrawals and I am sick, I'd much rather us go out there, see that person, evaluate that person, figure out if there's anything that we can do for that person, instead of just going, yeah, call your clinic and let me know what happens, and then hang up and then leave them out there in the wind on their own, right? We don't want to do that to people, and we have done that, trying to push us away from that. So when somebody calls and says, I'm sick, let's go see them, let's evaluate them, let's have that conversation and say, okay, look, you just missed all your appointments, you just haven't been to the clinic, let me call community care, especially if it's open, right? Like if it's a Tuesday at 3 o'clock in the afternoon, I'll Connor and he'll be like, oh, if they can get a bridge script, they will get you a bridge script and you won't have to do it. They're trying to conserve our resources even more so than we are some days, because they don't want to push us into a situation. That all makes sense? Comfort meds considered, if somebody is saying,
I unmuted this. Sorry, Mike, I just wanted to clarify so that folks are sure if they see that slide, they're seeing the right thing. My understanding is it's cows of 8 or greater. I know that's a hard thing to type.
yeah, well, okay, I was trying to do this from the hospital.
I know. Cool, thanks, Michael.
And then they came in and discharged her, so I got a little confused. So yeah, so if somebody is actively sick and has a COWS greater than 8, like, let's go ahead and dose that person, right? Even if they're established with the clinic, even if the clinic is open, even if the clinic is calling in a bridge prescription, let's just go ahead and dose them and make them feel better so that they can sort through going to the pharmacy and calling the clinic and going to do all this. That makes sense? Consider comfort meds. I put it in here, and since you're here, you can answer this, whether or not this is a good idea or not. But I put it in here that if you're going to deny somebody treatment, that you should probably call online medical control and let them know, like, hey, this person's sick, they're complaining of something, and I'm refusing to give it to them for a reason.
Yeah, so this is a technique that we do need to use sometimes, especially in integrated services, right? Sometimes saying no is actually the best thing for that patient. Because, so yes, there is the risk of, and that's why you're gonna call us instead of making that decision by yourself. Yes, there's the risk that they'll go out and use, but to some extent, like at some point, we have to be the grown-up to know to push them into being actually regularly. That's where it becomes a judgment call, is like, how likely do I think that there is to be harm from going out and using versus how likely do I think there is to be benefit of, hey, you can't keep using EMS. It's the same kind of philosophy behind a lot of other stuff that we do in integrated services, right? Like the emergency department is not your primary care doctor. It shouldn't be your primary care. Sometimes we tell people, no, we're not going to take you to the ER because I need you to quit using 911 because that's not where you're going to get your best care. But your best care is going to be at the clinic where you have continuity and people paying attention, following up, consistency, and all the rest of that kind of stuff. So sometimes, like the direction that we've given integrated services medics, right, is go do the right thing for the patient. Like make good decisions, do the right thing. The end. Sometimes the right thing for the patient is to refuse them our services in order to force them to be more consistent with their better, like long-term established. And to keep us available for the more acute, remember, like we are still a 911 service, right? Even in integrated services, we are still 911.
Yeah, absolutely. Yeah, and that's exactly being the grown up in the room is one of those ones that I use a lot of times, is because sometimes like the patients, they know a lot of stuff and they're driving their care, and I want them to be an active participant in their care. But at the same time, sometimes somebody else got to come be the grown up in the room, go, no, don't do that. That's not something you should do. That's a terrible idea. That's bad. Don't do that anymore. Like sometimes we have to have that conversation. But if somebody's calling you and saying I'm sick, let's not default to, hey, go back to your clinic, right? Like, let's go treat them first, make sure they're okay first, because I guarantee you that if I called Weems or Matt Hunt or anybody that, or Dr. Oshbach or Dr. Finno or any of the MAT docs, and I said, hey, your patient called us, they were actively sick, and I know you've asked us not to dose this person because you want them to come back to the clinic because they need to do their things. I went ahead and dosed them anyway because they were sick one time, and we sent them back to you tomorrow morning. They're cool with that. They're not going to be offended by the idea that we've dosed one of their patients that they're asking us not to. Make sense? Yes, ma'am.
And primarily for the new chippers in the room, this is not a decision you should make in a vacuum. This is something you should be, like, if they're on duty, you need to be talking to the SUP team before you tell somebody no, because they know their clients, they know what their baseline is, they're going to know any other factors that are involved. So please do not make that decision in a vacuum to tell somebody no.
Right. Couple of the other things, I forgot what all I put in here for this one, to be honest with you.
Oh, your hand up.
I was just gonna say, we don't even do this unless we have.
It's good, yeah.
Anyways, we generally don't do this unless we have like a pretty extensive history, so.
Yeah, this is a conversation between all of us. What I put in here is this is a temporary solution to a larger problem, right? Does that make sense? Like, this is some behavior modification stuff that's happening within the clinic that we are just trying to back up the clinic because it's not the right move for the patient. So we're gonna go into this with you guys. Everybody else kind of knows that one. Buprenorphine, I want to real quick cover this because what's happening right now is the docs, when they get an online medical control call for somebody who has experienced precipitated withdrawal after receiving Narcan in the field, and they have a CALS of greater than 8, they're saying, hey, let's go ahead and send one of the responders or one of the CHIP people out there to do that. So you guys are getting this call. We're working on a protocol, a COG, to make this easier, so it's less time consuming. But as of right now, we're going to treat it as initial enrollment. So the concept is, here's what happens, right? Narcan enters the system. It basically comes in and pushes everything off the opioid receptor, okay? And those mu receptors. Now, people who use on a regular basis that are struggling with opioid use disorder, that can cause precipitated withdrawal and make them actively sick, right? You can treat that actively sick with buprenorphine, right? If you can get the buprenorphine on board before the opioids jump back on the receptor, because I know we've talked about how Narcan is a temporary thing. Like you administer Narcan, it's going to start to wear off in 90 minutes to 3 hours, somewhere in that window, right? So we're kind of in a time-dependent type situation of when we can give the bupe, right? And it's not necessarily time-dependent of saying, okay, you need to be there within 90 minutes to give buprenorphine. You need to give them buprenorphine in that situation prior to the cows getting above an 8. Does that make sense? So basically what happens is the buprenorphine, what's that?
All right, before it goes below an 8,
Correct, like,
instead of above.
okay,
Sorry.
So yeah, the numbers are all screwed up today, greater than, less than, whatever. But bottom line is, if somebody has received Narcan, what's happened is within the body, the Narcan has pushed the opioids off the receptor. Now that receptor doesn't have any stimulation, and that person is experiencing withdrawal symptoms, okay? And that person's actively experiencing withdrawal symptoms, you can treat that person with buprenorphine, right? Provided that their CALS score is greater than. Makes sense? Okay. The new protocol we're going to work on, I don't want to confuse anybody, but we're going to try and shorten some of the time and maybe let's start to at a score of 16, but we're not quite there yet, so I don't want to confuse anybody with it. But if you get a call for somebody who's experiencing withdrawals after Narcan, if we can get buprenorphine on board beforehand, let's go ahead and do that, because even if they're not willing to engage and start into a program and let us dose them every day, we've still protected that person from overdose because buprenorphine has such a strong affinity for the receptor. You've got at least 24 hours that you've provided some level of protection for, and that's why they're sending us to do that. Does that make sense? So that's where, because we had this conversation the other day, Dr. Abraham and I were talking about it. She's like, the idea of putting buprenorphine in there, you don't have to worry about that person going out and using it again and relapsing and overdosing. That all make sense? So there's more to come and more to follow on this, but I want you all to know about this just in case.
On that in particular instance, how do we feel about individuals getting an emergency dose of buprenorphine post Narcan when they do not use significantly enough to go into withdrawal?
If they don't use significantly enough to experience withdrawal, then we should not be called to give them buprenorphine in that situation, because you still want to have a CALS of greater than 8.
That's circumstances where individuals are overdosing multiple days, but don't qualify for opiate use disorder, like in the clinics. Reached out to multiple clinics with integral care, community care, whatnot, but life is causing them to feel pressure that they feel like they need to alleviate some of that pressure with like fentanyl use. So now we have responded to like 3 overdoses in a row. And, now there's a risk of, are we doing a detriment to this person, Narcanning them and then repeating the cycle, even though they don't qualify for opiate use disorder, but we do have a medication that might be able to help stabilize that?
So the conversations I've had with the addiction medicine docs about it, in that situation, what they'll do is they'll start it at like a 2 milligram dose and then a 2 or 4 milligram dose of it. And they'll still start them on it because the cravings and all the risks and all that reason is there. In our situation with an 8 milligram dose, there's just not a space for us to start in that situation. So we need to get them connected to another program essentially in that situation. Make sense?
Yeah, perfect.
Try not to go over real quick. This is just a reminder to let me talk about the alcohol program real quick.
All right, Mike, I have one little quick point on the last slide. This idea of giving bupe after Narcan.
Yes.
We don't have standing orders for it now. It's something that's coming in the future. So if somebody encounters that situation right now, It's an OLNC situation, right?
No, if you're experiencing opioid withdrawals and you have a CALS greater than 8, we have a protocol for that, so you can go ahead and start that.
So
So we're gonna treat it as such for there. And just treat it like a normal enrollment as a new dosing as we're starting somebody.
it's initial enrollment.
Correct.
Okay.
When we get a new COG for it, the idea is to be able to start at a 16 milligram dose because there is no risk of precipitated withdrawal. But we're gonna do that at a CALS greater than 13, and so that's the whole thing.
Wait,
And you keep saying greater than 8, you mean 8 or greater?
Yes, sorry.
Your cows of 8.
Yes. Everybody understands the minimum CALS
I
is
just want to make sure that
if it's what it means, right?
8 or greater.
So,
When you are you talking about the?
as far as the alcohol program goes, real quick, and I'm sorry for going late, but I wanted you guys to know this. Anybody who has Pulsera can handle this call, right? PRU or responder or anybody, eventually they'll get to, one second. Eventually we'll get to a place where the sobering center is going to have their own Pulsera and kind of contact the PAs for it. But for what it is we're supporting people that are trying to get into treatment, right? We're trying to support people that are in that scary place in between using and recovery. And so that's what we're trying to do. And we use medication for that. The baseline is a CWA score of 10. You're only going to get these calls from the sobering center, which means that they've had a medic there doing CWA scores, monitoring this person, keeping an eye on them, getting a good history. We have not seen any clinical errors or like differences, a lot of huge differences between what they come up with and what we come up with. So that's why a PRU or anybody could really handle this. They're just going to reach out to C4 if they have a CWA of greater than 10. And I believe 17 is the top end, right? Okay. And if they're above that, if they're outside of that range, below 10, they don't need us yet, right? Above 10 or above 17, they're probably too close to having a seizure, and we're probably going to punt that one over to the ER. That makes sense? So one of the things about the alcohol program, the idea is they're going to stay at the sobering center until they can go to treatment, right? That's the whole point of it, is that they're going to stay there. Now, we've had a few situations where our providers have been called over there and they've been asked to do this, and the person's like, I'm not staying. You know, at some point, then you got to be the grown up in the room and be like, well, then that's not really the spirit of what we're trying to do, and make sure that we address that, because we should be working towards the goal of going to a program. Sometimes at the sobering center, they haven't had a chance to talk to the counselor yet before they're getting sick, so they can't have anything going towards moving to treatment or any of that stuff yet. But the counselor's going to be in the morning, or they're going to be in tomorrow or something like that. Let's still support them while we're waiting to get them connected to the treatment. But that should be the spirit of where they're trying to go, is to be connected to a program. That all make sense? Any questions about the alcohol stuff? Okay. So the rest of this is some scenario stuff that we're gonna. Oh.
You're good, you're good.
Heard it different ways, and I just wanted clarification from all over the place. Are we able to treat alcohol withdrawal with, like Arbor said, in conjunction with the Librium script, with the goal of?
If a doc tells you yes, then yes.
Okay.
But that's gonna have to be an online doc thing anyway, so let them get to that place. I know what happens a lot of times is it's usually in the evening time where we can't get to the pharmacy, we're not quite there, whatever. A lot of the docs or PAs have been like, okay, let's just give them like, I forget what they're doing, how much Versed that they were giving them, but they're giving them a low dose of Versed and trying to buy some time to hold them over until we can get to a pharmacy and get the Librium thing started and all that kind of stuff to get them through that. It's an online medical control. We don't have a COG for that just yet. So if that situation comes up and you're interested in saying, okay, this person is close to getting sick, we're not able to get the prescription or whatever, something like that, you could talk to the doc or the PA about doing that. But that's an order that you have to get from them. So it's not something we're willing to do yet. Sense? Cool. The rest of this is hanging out and doing some scenarios with our new folks and kind of doing a deeper dive on the substance use stuff. That kind of satisfies all the stuff I wanted to give everybody for MI6. Has anybody got any questions about any of the substance use program stuff?
Oh, hey, I just wanted to clarify, because I think I misheard something. So it is
It's above an 8, Jesus.
No, we were making sure that we had a distinction between the enrollment, right? The criteria for enrollment, which is going to be 8 or greater. And then separately, the post Narcan tube administration. Is that right?
Yeah.
I think you're saying they're the same.
Yes, they're both greater than 8. We're treating everything as an initial enrollment until we get a new COG reading.
And you're talking about the 16 in terms of initial enrollment.
Eventually, we're not there
Okay.
yet.
Not yet.
So I didn't want to throw that number out there because I want to confuse anybody, because we're not doing it yet.
So the post Narcan dupe administration, is that currently active yet?
So what's happening is
Because I know you're working on it.
field crews are calling online medical control and saying, hey, this is a high risk refusal because this person is exhibiting symptoms and they seem like they're actively in withdrawal in pretty bad shape. So they're calling online medical control. Dr. Abraham told me the other day, yeah, when they tell me that, I'm just saying send a chipper. Like that's what she's saying. And so I want everybody to understand the science behind it's possible to give somebody buprenorphine, but what are at really low risk. It's actually a lower risk situation than an initial enrollment, provided they're having enough symptoms to have a CAL score of greater than 8.
8 or greater.
8 or greater.
So just start with
Greater than
A.
I have one real quick, just awareness thing, especially for our new people. Librium's only an option when C4 is open. So if C4 is not open, Librium is not on the table, correct?
Yes, absolutely.
I have a clarification question.
Yeah.
If you're administering a post-Narcan dose of buprenorphine, is there a preference for renewing PCR, or can you just do an addendum to the cruise?
You can take over their PCR. You can take the one from the field crew. Couple things I thought of while James was doing his thing. For you guys that are interested in Sublocade situation, Karma seems to be the only place that really does, or it's one of the private practices from MAT that's doing it. Our methadone rule in the COG is 72 hours post methadone, and that's still kind of questionable. Like James said, it's about 5 days. In the clinic, setting, when you're transitioning somebody from methadone to buprenorphine, they typically do it about a month. Like they do like a very slow transition from one to the other because methadone is such a long acting opioid and it's so hard to get enough distance from it to be able to safely give buprenorphine or Suboxone. Yeah, and then methadone dosing, he mentioned how methadone dosing works. Typically you go 6 days a week in person to the clinic between the hours of 5:30 and noon ish, give or take 30 minutes to an hour, depending on the clinic. And then on Saturdays, they have to take a lockbox with them to the clinic so they can get a take-home dose for just Sunday, and then they come back on Monday. And so that's typically how it works for almost all the methadone clinics in town. If it's after 2 o'clock in the afternoon, you ain't getting methadone today. There's nothing wrong with starting somebody on bupe and carrying them for a couple of days to get them started on methadone. We did that just the other day as well.
Juliana wants to ask a question. She's gonna give herself.
Hey, Mike, can you hear me?
Yep.
Can you just real quick readdress when we were discussing Librium bridge scripting with the sobering center and C4? Can you readdress what those two numbers? You said a minimum CWA of 10 versus 17. Can you just reconfirm what those two numbers represent? I think I misunderstood something you said there.
Yeah, so essentially what it means is if their CWAT is less than 10, they're not experiencing enough withdrawal symptoms to go ahead and start Librium. If the CWAT is greater than 10, they're exhibiting enough symptoms to where it's the PAs and the docs are saying, okay, at that point, we'll call in the prescription for it. And the 17, when the score is 17, it means that they've gone too far beyond the threshold and we don't have enough window of time to get them the medication and get it on board prior to sending them over there. And so they're just going to send them out to the ER to get them dosed there.
And then not to
Resave it.
But 14, so 14, if having history of seizure due to alcohol withdrawal, then you send them to the hospital.
Okay. For those of you who didn't hear that, the CWAT is 14 or higher
Have a history.
and have a history of alcohol seizures.
but no history of alcohol, no history of seizures due to alcohol withdrawal, then it would be a 17.
And with no.
We see, so at that point, we would just call a unit in to take them next door to Del Seaton or, you know, wherever.
You're not even gonna get a call, sobering center's gonna handle that, and you shouldn't even see anybody outside of those windows, outside of the.
Gotcha. Okay. I see.
You shouldn't be involved in any of that if it all works the way it's supposed to. However,
Okay.
take a lot of turnover, sometimes people miss things get happen, shit happens. You may do it. But just so you know, that's where we're shooting. Make
Thank
sense?
Yes, sir.
Anybody else got anything else? Questions? We're gonna hang out here and be doing substance use stuff with the new folks. If you've got other questions and you want to stick around or hang out and participate, feel free. Sorry to keep you guys late for MI6, but I think we went over by 10 minutes, my bad. But unless Randy, you got anything else? Anything else for MI6 stuff?
I do have one, I'm sorry, I don't want to spend too much time on this issue, but a quick clarifying question again on the initial enrollment in BBP. If our field crews administer Narcan, they call online medical control for high-risk refusal. Doc sends an integrated services responder as viewed in their pocket. That responder should assess the way they normally do for BBP enrollment and dose if COWS is 8 or greater, starting at 8 milligrams, the same way we always do, right? You got all that. But also part of our standing orders and practices include the fact that the person has to be willing to participate in the program, set up a follow-up appointment, all that. Is all that still in place, or are we offering this kind of regardless? I mean,
So that's a great point. That's one of the things I wanted to address. I was just trying to rush through. Essentially what it is if you dose somebody in that situation, say, hey, okay, you don't have to engage in the program. You don't have to get connected to, but we'd really like you to. So why don't you just see how this feels, and we're going to follow up with you tomorrow and still make the plan for us to follow up tomorrow. And it's going to probably be one of us or from the substance use side that's going to make sure that we do that follow up the next day, and then be like, hey, do you want to let us do this? Do you want to go ahead and keep doing it? Because what we're doing also in that situation is you're giving them a taste of what sobriety can feel like and how well those medicines can work. And so giving them a day to think about it or overnight, say, hey, if you need more, if you start to get sick again, call us back and we'll keep this doing and we'll go ahead and go forward from there. This might be a great launching pad for recovery for that. The odds are we're probably going to get a lot of people going, you know what, man, I'm not ready. I'm going to do what I'm going to do. And if that's the situation, fine. Here's our phone number. Call me when you are ready. We'll do it that way. But for today, let me give you the dose and let you make you feel better. And let me support you while you're sick.
Thanks, Mike.
That makes sense?
Thank you.
I think some of the test questions I sent, I didn't actually get to cover, which was for an initial enrollment, monitoring is an hour after you give a dose. That's all in there. For an emergency dosing, monitoring is 15 minutes after you give a dose. I don't remember what else I put in as questions. It's all stuff you should know, except for you guys. So. We'll get to it with you guys.
Was it maybe the emergency follow-up dosing timeframes? Is that maybe?
Yeah, so emergency dosing and follow-up dosing is 15 minutes of monitoring after medication's been imbibed. And then for initial enrollment, it's an hour after the first dose, 30 minutes after the second dose. Cool. Let's take a break for you guys, and then we'll kind of take about 10 minutes, and then everybody else.
Thank you.
Interesting. It's like